Hello and welcome to this talk where we will review the morphological features of focal lung opacities that are predictive of benign and malignant etiologies. My name is Miranda Siemienowicz. Thank you very much for joining me. People tell me that chest imaging is non-specific. That is not true. And as you will see in these cases today, there are a number of morphological features pertaining to focal lung opacities that, when interpreted as a constellation, allow you to arrive at a working diagnosis of infectious or inflammatory versus neoplastic causes. And that's the difference between empirical treatment with antibiotics and then follow-up CT in 6 weeks, or progressing to percutaneous biopsy or even theatre and all of the associated risks. And what I want to move away from is the referring clinician arbitrarily choosing between these two different workup algorithms based on a non-committal radiology report, or worse yet, biopsying everything that comes through the door, to a greater separation between these two differential diagnoses. And that's the difference between appropriate patient counselling and contextualising that risk of malignancy, and minimising unnecessary, inappropriate biopsies, as well as giving you the opportunity to communicate more specifically and accurately with your referrer. Since time immemorial, or at least since 1993, radiologists have interrogated and attempted to quantify the predictive capacity of different morphological features of focal lung opacities. From the clinician's perspective, there exist a number of validated clinical risk calculators which take into account patient demographics, the personal and family history of lung and other malignancies, and what is usually a very modest interrogation of lesion morphology. And that's what we're drilling down on today, because this is where there is the opportunity for profound value add from the radiologist in terms of swinging that needle towards or away from cancer and directing the most appropriate workup algorithm. And how do we do that? We do that when interpreting these cases by asking over and over again in different ways one fundamental question: who is in charge? Is there a process that is superimposed on the normal background lung parenchymal architecture, which remains recognizable and visible despite the presence of the lesion? Or does the lesion itself drive the local structure with distortion and destruction of parenchymal architecture? The features that we look at are the lesion margin, lesion proportions, the color, by which I mean the appearance on post-contrast imaging, any radiations emanating from the lesion, and an analysis of the lung surrounds. When we talk about lesion margin, what we're looking for is evidence of that normal background lung parenchymal architecture. We're looking for the features that show us that the lung is in charge, that the architecture is preserved, and what we're looking for is that secondary pulmonary lobule. So you all learnt about it, you thought you'd never have to think about it again, but it's that 1 to 2.5 centimetre polygonal structure that is a 3D tessellation throughout the entire lung volume, bounded by interlobular septations, and at the centre of which is the terminal bronchiole, a branch of the pulmonary artery, and this fills the whole lung parenchymal volume. It's identifiable by its typical polygonal appearance, often hexagonal in structure, and we look for that when we're interpreting these lesions. So here we have a case where we've got a focal lung opacity in the left upper lobe. There's some heterogeneity in internal density, there's cavitation with a little locule of gas, and when we look on the lung windows, we're analysing that lesion margin to determine what is the morphology, what are the characteristics, and what are the clues to the underlying process. And if you look at this anterior and lateral margin, you can see these hexagonal polygonal structures that are the normal subpleural lung here that are butting up against the margin of a lesion. We've got these 120-degree margins, we've got these linear radiations here, which are the thickened interlobular septations, and 3 normal secondary pulmonary lobules that come up right up against the mass-like consolidation, which is what this lesion is comprised of. And then the lesion itself is filling these lobules, showing you that the lung here is in charge. Now, you would never look at a fracture in just one projection. And so you would never look at a lung lesion in just one plane, because the lung is a three-dimensional organ. Lung lesions are complex in their geometry in 3 dimensions, and we always review everything on at least 2 different planes. And when I scroll through this lesion on the coronal image, I can again see those beautiful polygonal margins with straight lines, with 120-degree angles, with this polygonal morphology here. And all of this tells me that this is infection, this is a don't touch lesion. Follow up CT in 6 weeks, and that's exactly what we did, and we see that the lesion has resolved. There's just some thin post-inflammatory bands, that cavity is gone, the lung is healing, and this is a focus of infection. As those polygonal margins begin to organize, they become scalloped, they become rounded, they become concave, and we look for that when we assess the lesion morphology. So here's another lesion, this time in the right upper lobe, focal opacity in the lung, and when I scroll all the way through it, you can see these beautiful concave margins. And this, again, is a clue that what we're looking at is a post-infectious focal organizing pneumonia that's becoming retractile, and that scalloping is typical. So when you have pneumonia in the lungs, you remember from histopathology that we start with red hepatization, with progression through to grey hepatization and resolution. So the red blood cells that are in the inflammatory exudate are consumed, fibroblasts lay down fibrin, which is resolved by macrophages. And as the whole lesion resolves, what we see radiologically is these concavities with organization and retraction as part of that organization and healing process. On the coronal images, we've got a beautiful concave inferior margin. We've got an absolutely beautiful scalloping here medially in this lesion, which is clearly a post-inflammatory process. Look at the way that the lesion curves towards and along the bronchovascular structures as they come back towards the hilum. This is the shape of a consolidated and atelectatic lung segment. As it comes back towards the hilum, it's the shape of the lung is in charge. We follow up this lesion a few months later, and we see a thin post-inflammatory band residual scarring from this inflammatory process. That's as opposed to a malignant morphology, which we see as microlobulation. And the reason that we get that appearance in lung cancer is because of the heterogeneous growth rate of malignant lesions, which occur throughout the volume of the lesion, and we see this as a margin on CT. Let's have a look here. Lesion in the left upper lobe, patient with advanced destructive emphysema, and when we scroll up and down through this lesion, you can see beautiful microlobulation here that clearly shows that this is a malignant lesion. Here we go, lobulation, lobulation, lobulation. And when we look on the coronal images, again, we see this beautiful microlobulated margin, and all the way at the anterior aspect of the lesion, we've got this little cluster of lobules, a clear malignant morphology. Another small focal opacity in the left upper lobe, again, a patient with mild centrilobular emphysema, risk factor for malignancy, but also risk factor for pneumonia. Remember that the mucociliary escalator is paralyzed by exposure to cigarette smoke, so when you're doing that multiple times through the day, you've got a prolonged proportion of time that the mucociliary escalator is non-functional. You've got accumulation of secretions in the airways and the lung parenchyma, and a perfect medium for the cultivation of infection. This was reported as cancer, but when you and I scroll through this, what can we see? We've got a little central locule of gas, so there's some cavitation within the lesion, but there is a clear polygonal morphology to this. We've got a beautiful 120-degree angle here. We've got this hexagonal structure, a budding pleura, straight edge here. And you would never assess a fracture in just one projection. Let's look at the coronal. And you can see a single secondary pulmonary lobule completely outlined by consolidation. The lung parenchyma architecture is respected. This is a beautiful, normal appearance of lung architecture. The lung is in charge. This must be infection. Anyway, somebody got upset. They've done a PET, which doesn't help because infection is a highly metabolically active process. So is high-grade malignancy, and this is not going to differentiate between the two. The patient changed institution with their care, and a very short interval CT was done only 2 weeks later. We already see how much this has increased in size. There's a much larger cavitary component. The lesion now is contiguous with some ground glass opacity. It's become more ill-defined. It's more ovoid in general morphology. It was reported as rapid increase in size presumed malignancy. And I'm just going to stop there for 1 second and talk about volume doubling time. This is the time it takes for a lesion to double its volume, which is an increase in diameter of a spherical lesion by 26%. And we know that the average volume doubling time for a solid lung cancer, that's solid lesions, this is a cavity, but the solid lung cancer average volume doubling time is 100 days with a range of 30 to 500 days. That seems like an enormous range, couldn't possibly be of any clinical utility when assessing cases, but just think for a moment about what that means, because what it means is that if you have a volume doubling time of less than 30 days, then infection is much more likely than cancer. Infection is what moves that fast. Cancer only very rarely moves that fast. And when I measure this out, the 2-week CT interval gives me a volume doubling time of 12 days. So this case is here to remind you that a rapid change in size or shape is much more likely to be infection. When we follow this up, empirical treatment with antibiotics, and we've got near complete resolution after a few weeks. Companion case, a lobulated lesion in the right lower lobe. We've got these large lobulations. Okay, what are we dealing with here? Flagged as cancer, repeat CT in 6 weeks, and it's significantly increased in size. Again, everybody's worried. So what are we actually looking at? We've got these large lobulations, and when we scroll up and down through the lesion, do we have a straight margin here? Do we have a straight margin here? Is this an angulated margin, or is this a lobulation? Well, you'd never look at a fracture in just one projection. Let's have a look at the coronal, and now you see an absolutely beautiful polygonal outline. I think this is 2 secondary pulmonary lobules abutting each other. They are filled with consolidation, and this is a very clear benign morphology. So what happened? Somebody got upset. They did a PET. It doesn't help. Highly metabolically active lesion, but with that morphological information from the diagnostic CT, you can direct the referrer and know that empirical treatment with antibiotics, follow-up CT is the way to go. This is a don't touch. When we repeat the CT a few weeks later, the lesion is nearly completely resolved. When we talk about lesion proportions, we're talking about a principle that you're comfortable with from thyroid imaging, from breast imaging. We're talking about the width versus the height. And when we see focal lung opacities, we're making an assessment of that greatest craniocaudal distance over the greatest axial dimension. The magic number from the literature is 1.78, which is another way of saying almost twice as wide as it is tall. This is taken from a historical paper from 2003 that examined 72 small lung nodules, 40 of which of them were benign, and came up with this ratio of 1.78 as being 100% predictive of benignity in that nodule group. Subsequent papers have used descriptors such as flat or sheet-like, and all of this is pointing back towards this being the shape of benign lesions in the lung. So let's have a look again at this case that opened the talk, and I can scroll up and down on it for you now. What are we getting out of the lesion margins? Not very much. This is rounded. Is this a slightly ill-defined straight margin at the top? Is this a very ill-defined straight margin at the back? I don't know. But you'd never look at a fracture in just one projection. So let's look at the coronals, and straight away as we scroll through this, you can see that this is much wider than it is tall. So this is the shape of a benign lesion. This is infection. This is don't touch. This is follow-up CT. Towards the back of the lesion, we've got some thick inflammatory bands, and these are thick. Remember those. The pleura is being pulled down. Is it tethered? Is that a worry? People get excited about the pleura. They think about pleural tethering as being a sign of malignancy, but I'm here to show you that as inflammatory lesions become retractile and organized, they will move the pleura. They will move the fissures. And that kind of fissural tethering is not a specific sign for malignancy, and we see this in inflammatory lesions all the time. We follow this lesion up a few weeks later, and it's resolved. So this is infectious, post-infectious organization, and a resolving benign lesion. Let's go back to our beautiful scalloped case from earlier, just to show you on the coronal once again, just how much wider than tall this is. So this is the shape of a benign lesion proportions in the lung. That's as opposed to this obvious cancer in the right lower lobe. Nobody would have any trouble picking that. It's got a lovely microlobulated margin all the way around. But I'm just putting this here to show you that the shape of a cancer is a ball. Lesion color. So let's look at some of these things on post-contrast imaging. We've got mass in the lingula, which has a rounded morphology. I can already see on this lung window that there's some heterogeneity and density, but let's have a look at what it looks like on the soft tissue window. And once we put this up, what we can see is that the enhancing component of this lesion has a very uniform density throughout. And what is most important here is that it's got internal vascularity, but not just some or a few vessels. It's got a sufficient number of vessels that would be explained by the volume of lung that you expect to see here. So if you imagine this was aerated lung, what we want to see here is actually just a few more vessels, because consolidation creates volume loss, which means vascular crowding, which means you want to see even more than you would see if this was normal aerated lung. And here they are, a couple of parallel vessels, a branch here, and when I scroll all the way down, I'm still seeing those all the way down here. So this is all vessels accounted for in this homogeneously enhancing consolidated lung, benign infection. Here, a well-defined low density region that is the abscess associated with this pneumonia. There's also a small paraneumonic effusion. What causes lung abscess? We've got staph, we've got streps, we've got gram-negatives and anaerobes. Very commonly in the case of lung abscess, mixed etiologies with multiple organisms. I don't get hung up about this because we know that only 60% of patients hospitalized with pneumonia will have a documented pathogen. And that's because the workup algorithm for these and the empirical treatment is broad spectrum. It covers lots of things. In the setting of an immunocompetent patient, the specific organism is much less important than sending the clinician down a benign infection-first workup algorithm and advising medical treatment with follow-up CT. Let's just go back momentarily to that right lower lobe cancer, because I want to show you the appearance on post-contrast imaging, and I want to show you the color of this lesion, because what we see is a few vessels passing through. That's fine. That's not a problem. Vessels will pass through cancer, but the background texture of this lesion is of diffuse heterogeneity. Let's have a look at it on the coronal, and you can see this coarse, diffuse heterogeneity throughout that cancer and insufficient vessels to account for the degree of opacified lung. Radiations emanating from lesions are one of my favorite things, and I think everybody else loves them too, because everybody wants to call a lesion spiculated, whether it's cancer or not. I want to reserve this term spiculation for lesions that I'm flagging for malignancy. So what we're comfortable with looking for is this corona radiata, the malignant spiculations, the malignant radiations. This paper from 2014 defined the corona radiata as being fine radiations that are about 4 to 5 millimeters in length. So they're short. And to the word fine, I also want to add the word dense, because what we're looking for is these very closely spaced fine radiations. These are radiations that are more numerous and more closely spaced than are accounted for by normal background lung architecture and the normal linear markings that you expect to see in the background lung, because the lesion is in charge. So here's a focal opacity in the left lower lobe. This is a primary lung cancer and unfortunately miliary metastases with innumerable 1 to 3 millimeter nodules throughout both lungs. You can see them all the way throughout. But if we go back to that primary lesion, when I scroll up and down through it, you can see the way it has these fine, relatively short radiations that are in excess of the normal linear markings that we expect to see in the surrounding lung. So here, radiation, 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 all the way across. These are fine, these are densely spaced, and they are much more numerous than what we tolerate in this region of lung, because the lesion is in charge. Benign radiations are sparse, they're more spread out, they're often longer, and they're often angulated because they comprise the normal background lung architecture. So here we have a focal opacity in the left upper lobe, a patient with moderate centrilobular emphysema, so their risk factor for malignancy, risk factor for pneumonia. And when I scroll up and down through this lesion, I see multiple sparsely spread radiations, many of which are quite long. So let's go all the way down to the bottom and just work our way back up. Here we have a cluster of secondary pulmonary lobules. So this is a lobule, this is a lobule. They are not beautiful and polygonal. They're a little rounded out. They're a little smaller than that 1 to 2.5 centimeter size that we expect to see, because the airways that comprise those secondary pulmonary lobules are, the air spaces are abnormal. So those alveolar spaces are coalescent, and that distorts that normal polygonal expected appearance that we see. But this is a septum, this is a septum, this is a septum. These are thickened interlobular septa that are reactive to an adjacent inflammatory process. Let's keep going. Septum, septum, vessel, vessel, coming up into another vessel that is angulated because it is branching. Here we've got a thin inflammatory band extending out to the pleura. And as we keep coming back up, there's a septum, there's a septum. We come up all the way through septum, 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 septum. The lung is abnormal, but the lung is in charge. Let's have a look on this soft tissue window. We're going to look at the color of the lesion. This is a non-contrast study. It would be even better if there was contrast on board, but even so, you can see that the color of this lesion is a lower density than that of skeletal muscle. This is a post-infectious mucocele, and based on the morphological appearance, based on the color of the lesion, this is a benign finding. So what happened? The patient went on to get a bronchoscopy. That's fine. Bronchoscopy is part of the workup in these lesions. In the setting of immunocompromise, a specific pathogen will substantially alter the medical management in many cases. Also, if the radiology is truly indeterminate, bronchoscopy and washings can be very valuable in guiding the next step in the workup algorithm. But in this case, we've got clear, benign morphological features. So when the clinician comes back to you and says, the bronchoscopy was non-diagnostic, we need a biopsy, it's your job to put on the brakes and to stop any further invasive workup, because when infection is at least as likely, in this case it's much more likely, infective, inflammatory, benign causes are the overwhelming cause and the confident cause of this lesion. But when infection is at least as likely, invasive investigation is not justified. And that's your job. What happened here? Somebody got upset, they did a PET. And this is a really great case that shows you the scenario in which an inflammatory lesion is strongly supported by findings on PET. We've seen multiple examples of where it doesn't help. But here we've got a lesion that has absolutely no metabolic activity within its interior because it's comprised of mucus, no living cells, within an abnormal airspace, a cavity, and a little bit of peripheral inflammatory activity at the margin, which is fine. PET appearances supporting what we knew from the morphological features to be a diagnosis of inflammatory mucocele. And sure enough, when we follow this lesion up, the mucus clears, the patient has a cavity that's probably with them for life, and a few post-inflammatory bands to show for their efforts. So what is the real risk to this interval period of observation? If we have a case that is equivocal between infection and cancer, what is the cost to the patient who may turn out to have cancer of waiting? So we do a follow-up CT in 6 weeks. What about those cases where you were 70% sure that this was infection? What about those cases where you were 51% sure that it was infection? What have you done if it turns out that it's cancer after all? So this is a very important question, and there's been a lot of work in the literature that feeds into the answer to this. And the study that I want to talk about today is this paper from 2021 that looked at 9,904 patients. That's almost 10,000 people with stage 1 lung cancer. What does that mean? That means a tumor that's up to 4 centimeters in size with no nodal or metastatic disease. And it looked at those who had a time to operation of 12 weeks, which means the time from the CT that showed ratioed the lesion to being on the operating table of no more than 12 weeks, and it looked at the rate of pathological upstaging. So a clinically significant increase in tumour size or the evolution of nodal or metastatic disease in that time interval. And it found that waiting up to 12 weeks was associated with a pathological upstaging rate of 0. Not one of their patients underwent pathological upstaging with a time to theatre of 12 weeks. So you have 6 weeks to wait. Let's have another look at another case. This is a patient who had a CTPA for query PE, and there was no PE. They've got airway-centered infective inflammatory change with some tree and bud opacity. They've got some mucus plugging. They've got background emphysema. So you've got loosened lung, you've got little centrilobular lucencies, and then interspersed more normal lung density. And then they've got what was called a spiculated nodule in the right lower lobe. So they've got a risk factor for cancer. They've also got a risk factor for infection. And when you look at this focal opacity and you assess these radiations, they are sparse, they are spread sufficiently apart to be accounted for by the normal linear structures in the background lung. These are thickened interlobular septa in this background emphysematous lung. The lung is abnormal, but the lung is in charge. And we know we can wait, and we do wait, and we wait for 6 weeks, and the lesion is decreased. This is an inflammatory process. The rest of their inflammatory change is worsening. They've got a moderate hiatus hernia, which is going to be contributory with a risk of aspiration. The patient needs a lung tune-up. They don't have cancer. Let's go back to the blackberry from the beginning of the talk, just because this beautiful microlobulated lesion has a fantastic demonstration of the corona radiata, and we'll just admire for one moment these fine and very densely spaced reticulations that are emanating from the lesion. They are closely spaced. They are in excess of the allowed linear markings that would be expected in this region of normal background lung, because the lesion is in charge. When we talk about the lung surrounds, we're looking for those features that we're familiar with interpreting in the context of infection. So we're looking at consolidation, we're looking at ground glass opacity, we're looking at tree and bud opacity. This paper that described the corona radiata described morphology of nodules as clustered, as being benign. So that's talking about the buds without the tree. That's talking about sub-centimetre nodules that arise in a group of adjacent secondary pulmonary lobules. And when they're within that local area as a group, that's a benign morphology, that's an endobronchial spread of infection, and a characteristic that is associated with benign lesions. Lung RADS, the reporting system that is used for lung cancer screening in different parts of the world, has a category of tree and bud opacity as being a negative screen. So we know that these are benign morphologies, and I don't think anybody would have a problem with interpreting this case of extensive tree and bud opacity that's involving the entirety of the right upper lobe, along with two near confluent cavitating masses, as being benign. People get hung up sometimes on post-obstructive changes in the setting of proximal lung cancer. And this is just a reminder that when tree and bud opacity is in the setting of segments that are supplied by airways that are clean all the way back to the hilum, this is an infectious process. The mass has to be upstream for this to be a post-obstructive lesion. So this is clearly a case of infection. We've got subsegmental consolidation in that anterior right upper lobe segment, and little clusters of tree and bud opacity in the medial middle lobe and in the anterior basal left lower lobe in a patient with active pulmonary tuberculosis. Another case, focal opacity in the left upper lobe, a rounded morphology, but see that it is contiguous with ground glass opacity that is involving the majority of that left upper lobe and extending down into the lingula, and that surrounding change is occupying more space than the focal opacity itself. It is the dominant process. So we are considering infection as being the cause of this lesion. and you'd never look at a fracture in just one projection. When we look on the coronal imaging and we scroll back and forth through that lesion, you can see that it is following that curve, that shape of atelectatic lung. And as we get up to that anterior superior margin, now we see polygonal margins. Now we see spared normal secondary pulmonary lobules butting up against the margin of the lesion. We see straight lines. We see ground glass opacity respecting the interlobular septa with its own straight lines. And this is the shape of infection. This is a don't touch lesion. This is wait for 6 weeks, empirical treatment with antibiotics. And of course, when we image a few months later, there's almost no evidence of there ever having been any abnormality. Here, focal opacity in the left upper lobe, cavitating. Let's have a look on the lung windows. And what I want to talk about here is I want to talk about measuring the thickness of the wall in cavitary lesions. People love to measure the thickness of wall in lung cavities. And then depending on who you read, you've got a cutoff for clearly benign lesions with a wall thickness of up to 4 or 7 millimeters, with a malignant wall thickness of being above 16 or 24 millimeters. And when I measure this lesion, I get a wall thickness, because I have to measure the thickest wall, that's the way it works, I get a wall thickness of 26 millimeters. But let's have a scroll down, because this focal opacity with central cavitation is clearly contiguous with patchy consolidation. And in fact, there are spared or relatively spared secondary pulmonary lobules within it. We've got polygonal structures that are themselves ground glass rather than consolidative within this area. Let's have a look at the coronal images and see that, again, that consolidation and ground glass opacity that's contiguous with that focal lesion occupies just as much space as the lesion itself. The consolidation is a dominant process, and these are morphological features of benignity. This is infection. This is follow-up CT in 6 weeks with empirical treatment with antibiotics. Somebody got upset. They did a PET. And it really doesn't help, because now this is a donut lesion. And now, again, we're obliged to think about it being a cancer, but we can see from that diagnostic CT those clear morphological features of infection, of a benign process. The lung is in charge. And when we follow this patient up after antibiotic treatment, we've got a post-infectious pneumatocele, we've got surrounding ground glass opacity, and the patient has resolved pneumonia. So that's as opposed to this. Cavitating lesion in the left lower lobe, but the surrounding lung is clean. When you scroll up and down through the entirety of this lesion, you can see that this is just normal, clean lung surrounding. There's none of that ground glass, there's none of that consolidation. And in fact, let's scroll back and forth through this and just admire that microlobulated margin of this lesion. This is a lung cancer. In fact, the interior margin is also microlobulated, which you don't often see. Very commonly, the cavity within a cancer is smooth and well-defined. Here, this is some fortuitous, rather delightful microlobulation within. But these are features of a cancer. Oh, look, the fissure is drawn in. Well, we know how much to think about that. Let's just go back to the axial images for a moment, because I also want to point out the way that these bronchovascular structures are curving in towards the lesion. They are curving in because the lesion is causing that local architectural distortion. It is bringing in those bronchovascular structures. The lesion is in charge. So what have we talked about? We've talked about looking at the margins of a lesion, looking for those normal secondary pulmonary lobules with the angulated margins, the polygons, the hexagons, the malignant contour with microlobulation. We've seen that even in small lesions with 120-degree margins, flat margins, as opposed to this sub-centimeter microlobulated adenocarcinoma included for your viewing pleasure. We've looked at the proportions of a lesion and being almost twice as wide as it is tall, being predictive of a benign etiology. We've looked at the color of lesions with vessels sufficiently accounted for in number for normal non-aerated lung, so increased in number from what you would expect to see in aerated lung and coursing all the way through consolidated parenchyma, as opposed to that diffuse heterogeneity of a malignant lesion. We've looked at radiations, we've looked at sparse, long, angulated, benign radiations and fine, thin, dense radiations of the malignant corona radiata, and that's also as opposed to those thick inflammatory bands that we saw earlier, which are again a benign feature. We've looked at surrounding lung, we've looked at lesions that are confluent and contiguous with extensive ground glass and consolidation as being the appearance of infection as opposed to clean surrounding lung. We've looked at how in any one lesion, multiple different features come together to improve your diagnostic confidence, and how you interpret all of these features as a constellation, because drawing all of these together is what allows you to interpret this fundamental question of who is in charge. And this allows you to create an environment where the patient becomes appropriately counseled as to their genuine risk of malignancy, an appropriate workup algorithm is pursued, there is minimization of unnecessary biopsy, and overall, fundamentally, an opportunity for you to communicate specifically and accurately with your referrer, which is what we're here to do. Thank you very much for your time.
Right. Didn't I tell you that would be awesome? Miranda is back in Radiopedia 2024 with another brand new chest imaging talk. I've had a sneak peek. It's really good. And we have some new cardiovascular imaging lectures and some chest-themed on-call case sets and anatomy review. Don't forget, we have some chest R posters too. We have a lot of chest stuff and neuro stuff and MSK. We have a lot of everything. There is a lot going on in this conference. I promise you that this is not going to be worth missing. So please do register. The registration page has all your options, including how to obtain free access if you reside in one of the 125 countries listed, and tiered and concession price rates. I'll see you at the conference.